কামরুল ভাই, আমরা কি শুরু করতে পারবো?
আমি বলবো তুষার ভাই, আরেকটা মিনিট। তুষার ভাই আমি বলবো। তুষার ভাই আপনি শুরু করবেন, জাস্ট 10 সেকেন্ড পরের থেকে কথা বলা শুরু করলেই হবে তুষার ভাই।
ওকে। Assalamu alaikum and good evening, dear participants. Welcome you all in today's ECG study group presentation. Today is our 63rd lecture session, and this is the first lecture session in the year 2022. Today we have amongst us Professor M. Atahar Ali. Sir will deliver lecture on anatomy and physiology. But before the lecture, I'd like to request Professor Rafique Ahmed sir to say some words regarding Atahar Ali sir, and then we proceed to the lecture. I request Rafique Ahmed sir to say some words. Rafique sir.
Sure. Thank you. Thank you, Tushar. Good evening and Happy New Year to everybody. This is an incredible feat that this session has continued for more than a year with so many sessions and participation of all the distinguished faculty from Bangladesh and abroad. I know Atahar for many years. He is the chief of cardiac electrophysiology at National Institute of Cardiovascular Disease and professor of cardiology. Atahar is a super clinician and a fantastic teacher. And most of all, he's from my medical college. And everybody knows Atahar in Bangladesh, so I'm not going to spend too much time. Atahar, if you could proceed with your presentation.
Thank you very much, sir, and good evening. And particularly, I like to welcome Dr. Rafique Ahmed, sir, and also I can see Dr. Abdul Jamil, Professor Mohsin Hussain, and our beloved Professor Abdul Salam, Naharuma, and many others. From today onwards, sir, we have decided to do 2 sessions in every month, that is 2nd and 4th Saturday every month. And in each session, there will be basic part for half an hour, followed by the related case discussion. Today, I will discuss about the anatomy and physiology related to ECG, followed by our Rafique sir's talk. That is the most awaited talks. That will follow my talk. That is the related talks regarding the anatomy and physiology. So in every day, 2 days in month, 2nd and 4th Saturday, Sunday, 2nd and 4th Sunday, same time, and 2 speakers, basic, followed by the related case discussion. This is our, so we want to do create some more interest among our students. Today's my lecture is entirely dedicated for our junior students and fellows, those who are interested, particularly as because this is anatomy and physiology related to our ECG. So I want to share my screen. Tushar, can you see my slide?
স্যার এখন পর্যন্ত দেখা যাচ্ছে না, ইটস ব্ল্যাঙ্ক।
Some problem, I think.
কার্সার দেখা যাচ্ছে শুধু হোয়াইট স্ক্রিন।
Some problem, আচ্ছা।
এবার আসছে।
Can you see?
Yes.
দেখা যাচ্ছে স্যার।
Tushar, can you see my slide?
Yes, sir.
So, good evening, everybody. This is anatomy and physiology related to ECG. So we can see the ECG is being recorded. That is, we can record the electrical activities of the heart from electrodes inside. On the left side of the screen, we can see there are some electrode catheters inside of the heart. This can be used for recording the electrical activities of the heart from inside. And on the right side, the electrodes are placed on the surface of the body. So we can record the electrical activities both from inside as well as from outside, placing the electrode. So ECG is the recording of the electrical activities of the heart. Heart is an electrical organ, and ECG is the graphic recording of the electrical activity of the heart. This is the ECG. And electrocardiography, that is, this is the electrocardiogram. And electrocardiography is the process of recording the electrical activity. So this is the simple, that is the difference between the electrocardiogram and electrocardiography. And recording the electrical activities from the inside of the heart is simply, many times is called the electrogram. So these are not so big difference. So electrocardiogram, that is ECG, and electrocardiography. So we can record the electrical activities from both inside and outside the heart. Not only the 12-lead ECG, there are some other ECG related tests like the bedside monitor, Holter ECG recording, exercise stress testing or TMT, ILR, electrophysiological test. So these are the some ECG related tests. Not only the 12-lead ECG, there are some many other tests which are basically dependent on the related with the knowledge of the ECG. And ECG is one of the tests is complementary to many other tests. All the tests are unique. As for example, in the lower part of the screen, we can see this is the chest X-ray showing the device of the heart. So what is the beauty of this test? So this is one of the unique tests. So ECG is also needed to interpret many of the parts of this test. Another is the echocardiogram. This can describe the function of the heart, anatomy of the heart, structure of the heart. So this is also unique, and ECG is also related with this test. And this is the angiogram. So these are the some common tests: ECG, chest X-ray, echo, and angiogram. These are the 4 common tests by which most of the cardiac functions we can interpret. And all the tests are actually complementary to each other, actually related to each other. And ECG is also used to interpret the many of the cardiac pathologies by itself, as well as in association with the X-ray, echo, and angiogram. So all the tests are unique for their interpretation, and ECG is one of the complementary to test by itself, as well as to many other tests. So this is the beauty of the ECG. And ECG is used for diagnosis of the some of the disease, not so too many diseases like the chamber size, coronary artery disease, conduction disorder, arrhythmias, channelopathies, and pacemaker function. So these are the common indication for use of the ECG, as well as ECG can be used as a supportive test in many other cardiac diseases like the pericardial disease, cardiomyopathy, congenital heart disease, heart failure, electrolyte disorder, pulmonary embolism, and thyroid disorder. So these are the supported tests, not the diagnostic test, but ECG can help in many ways to interpret these kinds of the diseases. So these are the common uses of the ECGs. 12-lead, this is what we are describing today. That is the 12-lead ECG. And this is how we do the ECGs. We have not shown that is the galvanometer of the ECG, that is the main machine. But these are the electrodes. There are the 6 chest electrodes as well as the 6 limb electrodes. There and that is the leads, 6 limb leads and the 6 chest leads. And electrodes number are the 10. So 10 electrodes used for recording the 12 leads, 6 limb leads and 6 chest leads. And these are the placement of the leads. I will not discuss this part of the, just I want to show as because this will be described in separate lecture. So actually electrodes are placed for recording the electrical activities of the heart on the surface. Limb leads number 6, chest lead number 6, and these are the position of the leads. And actually, by ECG, we can divide the heart into the two electrical chambers. So electrical chambers of the heart by this slide, that is the along the attachment of the tricuspid of the mitral valve, that is the fibrous trigone, the connective tissue between the upper part and the lower part of the heart that divides the heart in the supraventricular as well as ventricular part. These are the electrical chambers of the heart, that is the supraventricular and ventricular by this lying along the fibrous trigone, that is the area of attachment of the mitral and tricuspid valve. And the supraventricular means it includes the atrium, superior vena cava, that is sinus node as well as the AV node. So these are the supraventricular structure as a whole called the supraventricular, and all the structure below this is the ventricular structure. So this is the electrical chambers of the heart, that is the electrical, you can divide the heart into two parts, supraventricular and ventricular. This is the gross anatomy of the heart, that is the normal heart, that is the position in the mediastinum, that is the heart is in between the left lung and the right lung. We can see the anterior aspect of the heart. This is the what is seen in the mediastinum, that is the heart in the mediastinal position, middle mediastinum, and this is the gross anatomy of the heart, that is the anterior view. This is the part of the left ventricle, that is the anterior surface is composed on the left side with the left ventricle, and the middle part is the right ventricle, and the right side is the right atrium, and we can see the left atrial appendage of the upper left part of the heart, and that there is a great artery. So this is the anterior aspect of the heart. We can imagine the anterior surface from when we see about the anterior surface of the heart, we can imagine what are the structure of the anterior surface of the heart. So this is again the normal heart. This is the specimen of the heart on the left side, and just if we take the X-ray, we can see this is the X-ray of the heart. This is the right border, this is the left border of the heart, and these are the components of the left border and right border, and we know it. So just to keep in mind that this is the X-ray of the heart by which we can take an imagination about the structure of the heart, what are on the right side of the heart, what is the left side of the heart, and how the apex is formed. So this is the normal heart, and these are the borders of the heart. This is the aortic knuckle, this is the left border, right border, this is the area of the pulmonary artery. So this is the chest X-ray to define the size of the heart, shape of the heart, and the borders of the heart, and we can compare this chest X-ray with the specimen of the heart of the left side. So this is how we can, this is the another examples, and this is frequently used in the description of the ECGs regarding the, when we describe the ECG in terms of the angiogram, two views are commonly described, that is right anterior-oblique view, left anterior-oblique view. So these are the, we can imagine how the right anterior-oblique view, actually what is the position of the heart, what is the structure of the heart, when RAO view, that is right anterior-oblique view is described. This is the part of the right ventricle and the right atrium. Practically, the right ventricular right atrium is being seen, and the left ventricle on the behind, and the left atrium is also behind. The upper part is formed by the aorta. So this is the RAO view, and on the when it is the LAO view, we see the right ventricle just behind the along this line. This is the sternum. So this is the sternal position. That is right ventricle behind the sternum, and spine and the behind, that is the left ventricle along the side of the spine. So this is the left anterior oblique view. So these views are very commonly described in terms of the ECG description, in terms of the angiographic findings. So RAO view and LAO view, right anterior oblique view and left anterior oblique view. These terms are frequently used in description of the ECG. So, and we can think about the position of the different parts, components of the heart in describing this type of this. So RAO view and LAO view, and actually this is again the anterior aspect of the heart, and this is the electrical surface. Actually, practically what we described, this is real anatomical part. This is the specimen of the heart, and this is the real anatomy. And but here we can describe the actually electrical surface of the heart. Electrical surface means anterior surface, that is described in terms of the ECG, that is V1 to V6. Sometimes it is also described that is the extensive anterior surface, that also included the lead 1 AVL like this. So anterior surface actually practically restricted to the lead V1 and V6. This is the anterior electrical surface, anterior surface of the heart. This is the lateral surface on the left side. This is the lateral surface, that is the lead AVL on the, that is this is the position of the lead AVL. This is the position of that is the along the left shoulder. This is the lead 1 position. Apex, this is the V6 and V5. So on the left side, that is the lateral aspect of the heart. Actually, this is represented by the AVL 1, V5, and V6. This is the electrical lateral surface of the heart. And on the bottom, this is the inferior surface of the heart. And by ECG, it is actually described in lead 2, 3, and AVF. So these are the electrical surface of that. There is also another posterior surface. And this is described in terms of the ECGs. So electrical surface, there is the anterior surface, lateral surface, and the inferior surface of the heart. These are the electrical surfaces of the heart. And actually the heart is composed of the different kinds of the tissues. The myocardium is composed of the 3 types of the cells. The commonest is the that is the contractile myocytes. Another specialized cell is the conduction cell, and some are the impulse generating specialist cell having the special automaticity. So contractile cells, that is the contractile myocytes, conduction cells, and impulse generating cells. So these are the 3 types of important cells within the myocardium. And also within the myocardium, 3 types of the tissues. That is the myocardium, that is the composed of the myocytes, that is the myocardium, ECM, that is extracellular matrix, and also good component is the endothelium, that is the endothelial lining of the vascular wall, that is endothelium. So 3 types of the tissues within the heart also, and there are 3 layers of the heart. There is the endocardium, myocardium, and pericardium. So these are the terms frequently used describing the different aspects of the ECGs. So these terms are actually related to the ECG, and 3 types of cells, 3 types of tissues, and 3 layers of the heart. And all these are related to the 3 important properties of the heart. There is the contraction, conduction, and automaticity. These are the special, unique properties of the heart. These properties are not to any other organs of the body. Heart is unique in this sense, that is, it has got the contractile properties, conduction properties, and self-dependent, self-automaticity. So these are the 3 important properties of the heart. And this is the cardiac tissue. The cardiac tissue is specialized, unique in the sense that is different. That is not, it is actually unlike to the smooth muscle cells and the skeletal muscle cells, as because the myocytes are connected by the intercalated disc. And this intercalated disc can transmit the impulse from one cell to another. So when the heart is stimulated at only one part, like this area is stimulated, this stimulation can move to that other part. So actually, so this is the actually when the heart is stimulated here, this stimulation goes to these sides by this intercalated. So this is the unique quality, unique property of this heart. That is the intercalated disc by the gap junction. This can transmit the electrolytes from one cell to another. So this is the, and for this reason, the heart muscle is called the syncytial. But the syncytial characteristics may be lost in some pathologies, particularly when there will be some injury to the myocardium, as because at that time, the myocardium, the myocytes can be replaced by the connective tissues. And we know anatomically, physiologically, normally, the 1/3 of the component of the myocardium is myocytes, and 2/3 is the extracellular matrix. And this extracellular matrix is a dynamic component. The amount of the extracellular matrix can be changed in some situation, in some pathologies, in stimulation to the some of the neurohormones. So this is the dynamic component of the heart. And the myocytes again can be replaced by the extracellular matrix. And this is the region in some pathologies when the heart is dilated, the myocardium, that is the myocyte, that is the myocardial wall may be thin and gradually can be replaced by the connective tissues. These are the non-contractile tissue, non-conductive tissue, and these are the actually electrically inert, the extracellular matrix. And at that situation, depending on the position, the intercalated disc may be lost, and at that time, the electrical pathways may be zigzag, like this, maybe zigzag. And these pathologies are responsible for many kinds of the abnormal automaticity, abnormal pathology, abnormal electrical activities within the heart. And because of the scar tissue, because of this position, these are because of the loss of the intercalated disc, and because of the syncytial loss of the syncytial characteristics of the myocytes, either segmentally or globally. So this is another, again, unique qualities, unique properties of the myocardium, even at the physiology and during the pathology. And again, actually ECG is the recording of the action potential of the heart. This is the action upper part. This is the action potential of the heart. This action potential, this is the action potential of a single myocyte. And these single myocytes can be recorded by the, actually ECG is the recording of this action potential. You can compare the shape of the action potential with the ECGs. This is not similar, but this is actually recording the electrical potential. And actually ECG is the summated action potential. Summated means all the action potential of all the myocytes of the some parts of the heart, like the atrium or ventricle, some or regional. So this is the summated action potential of the ECG. ECG is the summated action potential. This is the action potential of the single myocytes. But this is the ECG is the action potential of the summated action potential of the part or whole of the heart. And it has got the three vectors. Actually, the ECG has got the three vectors: height. Actually, the vertically, this is the height. The timing along this line, this is the timing, and direction, actually in which direction it will move, like this. So this is the, actually there are three parameters, three vectors of this ECG. This is the vector quantity, and it has got the three dimensions, that is the height, timing, and the direction. Height can be expressed in terms of the millivolt, timing in millisecond, and degrees, that is the direction in degrees. So these are the three actually dimensions of this ECG. We have got like this. The ECG has got the three dimension. The direction is also important, and because of this direction of the, that is the mean resultant force or mean resultant direction, like the resultant direction of the P wave from this atrium, or resultant direction of the QRS complex from the ventricle, and it is the resultant direction of the mean frontal axis of the P wave or the QRS, and it is the position of the different leads that determines the shape of the ECG at the different leads. This is the position, that this is the lead one. We can compare the shape, that is the morphology of the ECG in lead one is not like that of the lead 2, and like not that of the AVR, and like not that of the, so the variation, there is variation of the different morphologies of the ECG at the different leads, and this depends upon the direction of the QRS resultant forces and position of the lead in terms of this resultant forces. So this will be described in another lecture. Just I'm giving the idea that actually this is a good explanation how the ECGs are different in different leads, and this is the actually morphology. And we can see here that is the resultant force is going from this area. This is the position of one lead. This is the position of the one lead. That is the resultant force is going away from this lead. So here will be the QRS complex, that is the ECG will be negative, and the resultant force is going towards this, actually this electrode. So the QRS, that is the ECG will be positive. So simple formula is that moving toward the positive pole of the lead, there will be upright wave will be recorded. So this is the simple formula, and these are the different kinds of the position of the lead. The position of this lead is like this here, like here almost right angle, and like here, like that is like the position of the AVL. So there will be variation of the shape and height and amplitude of the different components of the ECG depending on the position of the electrodes in relation to the resultant force, direction of the resultant force. So this is the very important ideas to explain why the ECGs are different in different leads. So here we can see that is the lead 1, lead 2, lead 3, AVR, AVL, AVF, like this. So the shapes are not uniform, different kinds of the shape because of this kind of the nature, and this is the formula by which. And another important ideas is that actually there will be depolarization. The cardiac cycle is composed of the depolarization and repolarization, and during that depolarization, the current is moves from endocardium to epicardium. The ECG electrode is placed over the chest wall, that is just over the epicardium. So we can compare that the electricity is going towards these electrodes. So there will be positive signature, that is the positive recording of the different components of the depending upon the position of that lead in terms of the movement of the ECG. But what I want to see, the repolarization happens in reverse direction. So as for example, in case of the lead V4 here, you can see there is a QRS complex is positive. The depolarization is happening in opposite direction. So T should be inverted. T represents the repolarization. But why that T is also in the same direction? The simple formula T follows is that this T follows usually the main positive components of the ECGs, main positive component in lead 1. The main component is the positive, so T will be upright. In lead 2, the main component is positive, so T will be upright, but the direction is opposite. But why it is happening? It is happening is because when the repolation happens, it happens from epicardium toward the endocardium, and again the endocardium becomes negative first. So the positive component of the depolarization remains behind. So always the electrode phase, this is the positive even during the depolation or during the repolation, and this is the meaning why the repolation records the movements of their component, that is R or T, in the same direction. So it will be explained again in the subsequent lecture, but there is explanation why the repolation happens in opposite direction, but the main components of the ECGs goes in the same direction. So ECG also can be compared with the parts of the cardiac cycle. This is the one cardiac cycle. We can see just the ventricular components of the cardiac cycle. That is the ventricular systole and the ventricular diastole. The ventricular systole starts from the QRS complex and ends at the end of the T wave. So from the beginning of the QRS complex to the end of the T wave, that is the QT, actually indicates the ventricular systole. QT actually. QT, the prolonged QT means prolonged ventricular systole. Short QT means short ventricular systole. That is the ventricular systole. And from the end of the T wave to the next QRS complex is the ventricular diastole. So ECG again can represent the ventricular systole and ventricular diastole. And again we know where is the actually first heart sound, that is at the beginning of the ventricular systole, the first heart sound, at the beginning of the diastole is the second heart sound. So also ECG can be compared with the first heart sound and second heart sound, ventricular systole, ventricular diastole, like this. So actually ventricular, but we can one thing we should remember, that is the ventricular depolarization and ventricular systole is not synonymous. Actually QRS complex is the ventricular depolarization. It is the ventricular depolarization begins, but the ventricular systole continues after the end of the T wave. And the T wave represents the ventricular repolarization, but the diastole starts after the T wave. So we should not be confused with the ventricular depolarization and repolarization with the ventricular systole and diastole. And ECG can be used for detecting the ventricular systole, beginning of the ventricular systole or beginning of the ventricular systole, and echocardiography at the beginning of the first heart sound and the beginning of the second heart sound, or in other words, beginning, that is the closure of the mitral tricuspid valve and closure of the semilunar valve. So in different ways, ECG can be correlated with the different components of the cardiac cycle, like the ECGs, heart sound, echocardiography, like this. So this is another beauty of the ECG. And this is one of the examples of the ECG. This is the normal ECG. Our Rafique sir always loves to show this normal ECG. We have to see the normal ECG. We have to understand the normal ECG. And this normal ECG has got, I have already described, that is the height. This is the height of the QRS complexes. So this is one of the magnitude, and it can be unit is the millivolt, and timing along this lining, it is the timing in that can be expressed in millisecond. And what I have described already, the direction, that is in which direction the P wave or QRS complex is moving in degrees. So these are the normal waves. The normal components of this is at the sum of the waves, like the P, QRST. This is the P wave, this is the QRS, and this is the T. So these are the normal actually waves, and there are some normal intervals, that is the QRS interval, T interval, like this. So interval, and there are some segments. So these are the different components of the heart, and this will be described in detail in subsequent lecture by Dr. Abdul Jamil. So these are the different components and intervals of the ECGs. And not only the there are some also abnormal waves This is the physiologically, these are the normal components, but in some pathology, we can see some of the abnormal waves like the delta wave, epsilon wave, Z wave, and fragmented wave. This will be also described in subsequent lecture. Delta wave, epsilon wave, Z wave, and fragmented wave. These are not the normal component, normal waves. These are the pathological wave, which means something else. So these are also some waves in terms of the ECGs. So this will also again be described. And what I have actually told, that is the along the horizontal line, it describes the direction. This is the ECG paper. This will be described in subsequent lecture. This is the standardization. That is the in ECG there will be standardization on the left side. This is the normal standardization. That is the 1 millivolt. That is the 10 millimeter. And along this line, that is the horizontal line. This is the timing. That is the normally the speed of the ECG recording is 25 millimeter per second. That is 5 big box. Between these two red lines, you can see 1, 2, 3, 4, 5. 5 big boxes, and 5 big box means 1000 milliseconds. So this is the normal speed. This will take 1 second to record in the ECG machine in their normal standardized procedure. And this 5 big box means the 25 millimeter. And there will be some small box within this 5 big box. These are the small box. This is the area of the small box. And each small box has got the 5 smallest box. Small box contains the 5 smallest box. One big box is 200 millisecond. That is the 0.2 second. And 5 big box is the 0.2 into 5. That is the 1000 millisecond. And one smallest box is equal to 200 divided by 5 equal to 40 milliseconds. So smallest box, 40 millisecond, one big box, 200 millisecond, 5 big box, 1 second. So this is the way we have to keep in mind these figures. Actually, this is the way how we can record. And actually, ECG records different components of the heart. That is the actually this is misplaced. Actually, this area is the atrial area, and it indicates the atrial depolation. That should be here. And this is the actually AVR. That is the AV nodal area. That is the PR segment. And this is the QRS complex, that is the ventricular depolarization. That is the different components of the ECG, shows the different activities of the electrical activities in the heart. And this is how we can compare and we can see the different areas of the heart. And ECG can tell the anatomy. As for example, on the lower part of the scene, we can see this is the normal heart, and this, the walls of the heart is thickened. That is the hypertrophied heart. And when there is hypertrophy, there will be changes in the magnitude, that is the amplitude of the complexes. So height of the QRS complexes. So that can be, so by which we can see that the ECG can tell the anatomy of the heart, that is the hypertrophy of the heart. So that will be described in a subsequent lecture. What is the message is that the ECG can tell the anatomy of the heart. Again, we can see here this is the P wave. The P wave is not normal. That is the one component of the P wave is more, negative part is more than the positive part. So that is the left atrial dilatation. This is the right atrial dilatation. So ECG can also tell us about the anatomy of the atrium also. So this is how the ECG used to describe the chamber size of the heart. And again, these are the different components of the conduction system. This is the SA node. SA node is one of the first components. This is the SA node. This is located at the junction of the superior vena cava and the right atrial junction. This is spindle-shaped structure. And this is actually subepicardial in location, subepicardial. And this is the region when there is pericarditis, SA node is involved, not during the endocarditis. SA node is involved mainly during the pericarditis because it is subepicardial location, and it is spared during the endocarditis. So this is the SA node, and it has got the highest automaticity, and because of this reason, it is the normal pacemaker of the natural pacemaker of the heart, and its conduction is actually conduction is medium category conduction, 1 millisecond per 1 meter per second. So this is the SA node is the one of the most important first part of the component with the conduction system. AV node is another important component of the conduction system. That is the conduction system is component of the SA node, AV node, His bundle branches, and the Parkinson system. These are the components of the conduction system. SA node, AV node, His bundle. This is the His bundle area. This is the right bundle. This is the left bundle. These are the Parkinson fiber. So these are the components of the different components of the conduction system. And the AV node is located at the junction of the interatrial septum in the lower part of the right atrium. Here it is located the AV node, and this is the subendocardial structure, and because of its subendocardial location, it is mainly affected during the endocarditis, not during the pericarditis. So this is very much vulnerable to be affected during the endocarditis. This is the AV nodal locations, and it has got the medium category automaticity less than that of the SA node, and actually this is the gateway of the impulses from atrium to ventricle, and it produces some delay, and this is the unique properties of the AV node, and by which it can produce the atrioventricular synchrony. AV node is essential for maintaining the physiology, that is atrioventricular synchrony, the important, most important, very, very important physiology of the heart, that is atrioventricular synchrony. And I have already told that is the some myocytes that got the, there is some pacemaker and the non-pacemaker cell. The action potential of the pacemaker and non-pacemaker cell has got some differences like this. This is the non-pacemaker cell. There is the transmembrane potential is minus 90 millivolt. In compared to the pacemaker cell, it is minus 60 millivolt. And this is the threshold potential. And the most important is the slow rising depolarization of the pacemaker cell during the phase 4 of the action potential. This is the reason why the SA node is the pacemaker of the heart. It can go spontaneously without any impulse. There is spontaneous depolarization, slow leakage of the electricity inside of the myocytes, going the threshold, less negative, and when it goes to the zero potential, then it suddenly voltage gated action potential. So this is why the SA node is the normal potential of the heart, and this pacemaker activities is normally restricted to the conduction system, that is the SA node, AV node, and the Parkinson system, highest in the SA node. But in pathology, this automaticity may be present abnormal in some parts of the heart, and this is how the ectopic beats can be produced by the abnormal automaticity. This is one of the example of the abnormal automaticity has happened outside the normal conduction system. And this conduction system histology can be changed with the aging process. As for example, during the aging process, the number of the cells can undergo reduction of the number of the cells. There will be fibrosis and calcification. So this is the reason the 6NS syndrome may happen. Also, this can be happen in case of the AV node, that is the age-related changes within the conduction system, particularly SA node and AV node. This is responsible for the 6NS syndrome, also the conduction that is degenerative, a complete heart block, that is the number of the cells, reduction, fibrosis, and replaced by the calcification. This is the age-related change of the conduction system. And the location of the impulse formation is also matter, as because, as for example, in case of the P wave, this is the normal location of the P wave formation, but in some abnormal situation, the P wave maybe can be produced here or can be here. And when this is produced here, this is the direction. When it is produced here, this is the direction. When produced here, this is the direction. And depending upon the location of the position, the P wave morphology can be changed. And this is the reason actually we can see the different kinds of the P wave morphology in the different situation. So, and conduction variation is also one of the important properties. The different parts of the conduction system has got the different categories of the conduction system. And this is the very unique properties of the heart. And because of these variations of the speed of the conduction at the different parts of the heart, it can maintain the synchronization, the sequential activation of the different segments of the heart. This is the unique property of the heart itself. And there is some differences in the conduction along the normal conduction system and the myocardial conduction, that is the conduction along the conduction system and the conduction within the myocardial conduction system. When the impulse is produced within the myocardium like this is produced within the myocardium, it takes longer time to be depolarized. So the QRS duration will be greater. So this is the reason why this is narrower and why this is wider. So this is the another physiology by which can, this is another example of showing the narrow QRS and wider QRS complexes. And we can see how the where the location may be the origin of these complexes. And this is the AV node. It can produces the delay, and this delay is responsible for the actually atrioventricular synchrony I have already told. And actually, this is the only gateway of the impulses from atrium to the ventricle. This is the only gateway, that is the atrium, that is the AV node to the atrium. But in some abnormal situation, there may be another pathway. This is another pathway. This is the accessory pathway, additional pathway. And this is the actually pathology of the WPW syndrome, when there will be some extra connection of the electrical connection between the supraventricular and the ventricular part. And this is the abnormal connection. When it present, it produces the diseases. And actually, heart maintains the synchrony. Actually, heart maintains the synchrony, hierarchy of the, actually, this is the natural situation, that the AC node is the normal pacemaker. The automaticity of the AC node is the highest, followed by the AV node, followed by the His bundle, followed by the bundle branches, and followed by the myocardium. These are the rates of their automaticity. And actually, heart follows this principle, NASA follows this principle, hierarchy. When AC node fails, AV node takes over, and when AV nodes fail, then the His bundle, when His bundle fails, this is the situation hierarchy of the natural physiology of the heart. That is the situation. And when the conduction system is separated from one another, there will be some changes that can be, the AC node is separated from here, and we can see the abscess of the AC node. That is abscess of the AC nodal activities like this. AC node is separated. So how the ECG can tell the anatomy of the heart? This is the reason why what I want to see. And another is that the AV node is separated. This AV node is separated. The impulse is coming up to the AV node, not beyond that. The impulse is coming up to the AV node, not beyond that. So there will be some escape rhythm from ventricle. So escape rhythm from ventricle. So impulse is coming at a higher rate from the AC node to the up to the AV node, up to the AV node, but the AV node fails to pass the impulse from here to downwards. So there will be some escape rhythm. This is the natural protection. So AV node is actually, myocardium is producing these impulses. This is the escape rhythm. This is the escape rhythm rate, nearly less than 20, less than around 25, 20 to 25. So AV node is, that is the dissociation. Atrium and ventricle is dissociated, separated, has their own rhythm like this. So this is how the, so again, I'm towards the end of my lecture. That is the actually arterial supply of the heart is very much important. Actually, this is the, there are three arteries in the heart. That is the two arteries basically, left main and the right coronary artery. The left one is again divided into the left anterior descending, that is the LAD, and this is the left circumflex artery. Left and LAD is very much important as because it supplies the 70% of the left ventricle, and L6 is 30% of the left ventricle. So this is the left main artery is very much important as because any problem in the left main causes nearly 100% of the left ventricular dysfunction. And this is the right coronary artery, particularly supplies the right atrium and right ventricle. And there is another term which is called the coronary dominance. This defines which coronary artery gives up the PDA, that is the posterior descending artery. It is the posterior descending artery from which artery it comes that determines the coronary dominant. That is the right dominant, PDA comes for the right coronary artery, left dominant, PDA comes for the left circumflex artery. So this is the three artery, and these arteries are actually functionally end arteries. There are some anastomosis, but these anastomosis are not sufficient to prevent the infarction when there is a blockage of one coronary artery. So these are the actually functionally end arteries. The anastomosis is not sufficient to prevent the infarction. So these are the functionally end arteries. Each artery supplies their own defined territories, on defined the segment, and these are the actually, and this is the anatomy, that is the blood supply, the coronary, that is the conduction system, very important. That is the AC node is supplied by the right coronary in case of the 65, and L6 by the 35, that is the 65, 35. And the right coronary again supplies the AV node and proximal part of the His bundle. That is right coronary, AV node, proximal part of the His bundle, and the posterior fascicle of the left ventricle. This is the right coronary artery. AV node, proximal part of the His bundle, and the posterior fascicle of the left bundle. And this is the LAD, left anterior descending artery. It supplies the actually distal part of the His bundle and the main His left bundle branch and the anterior fascicle of the His bundle. So this is the blood supply of the conduction system of the heart. And there is some problems of the rhythm during the conduction system, that is the myocardial infarction, that is the bradycardia and AV block in different situation. And nerve supply of the heart, there are two, that is the heart is controlled by the two systems, that is the sympathetic system and the parasympathetic system. The modulator of the systems are in the hypothalamus, And there are the cardiac centers in the middle oblongata, that is the sympathetic center and parasympathetic center. The sympathetic supply is predominant on the anterior surface than the inferior surface, and this is responsible for the increase in the heart rate and force of conduction, and afferent pathway is for the pain conduction. And this is the region when there is the anterior infarction, the heart rate is increased, and that is responsible for the VT and VF. And on the contrary, the posterior surface is predominantly supplied with the parasympathetic nerve, and this is the region when there is inferior infarction, the heart rate is reduced, and the blood pressure, and so this is the different kinds of the heart block. So there is variations of the sympathetic and parasympathetic such on the anterior and the inferior surface of that, and this is responsible for different kinds of the arrhythmias on the different situation. Again, this is the first slide I have shown, and this is the last slide again. This is the normal ECG, and you have to see why it is normal, what are the components of the normal ECG. Thank you very much for your patience hearing. Excellent. I'm taking the time a little longer. Thank you very much.
Thank you, sir, for your nice elaborative lecture. May I request Professor Rafique Ahmed, sir, to share his screen. Rafique Ahmed, sir.
Unmute yourself, sir.
Oh, sorry, couldn't hear me. So this is excellent lecture, Atahar. Thank you. And I was saying that it's very important to study anatomy and physiology. When I studied medicine, every time I'll study a chapter, if it is pulmonary medicine, I'll read about 10 minutes anatomy and physiology. And I think I still do it. From time to time, I'll go back to anatomy book, I'll go back to physiology book. So please try to nurture this habit. So what I would like to do is we have about half an hour. We'll go some ECG, and I would request participants to, I'm not doing questions today. It'll be, I'll show ECG, and if you could, one of you could volunteer and talk to me about this ECG. So this will be the ECG first one. Any volunteer?
Abida.
Sir, this is ECG, sir. There is heart. So if we see the ECG, the heart rate is about
125.
125. Yes, sir. Narrow complex QRS. There is actually, sir. It looks like, sir, there is sinus tachycardia, sir.
Okay. So why did you say sinus tachycardia?
Sir, because I can see the P.
Yes.
P wave. And P
So,
yes, sir. It's a regular P wave.
Yes. So you can see my pointer, right? So there is the P wave you are talking about, right?
Right, sir.
Yes, sir.
Okay. Yeah. Anything funny about this P wave? Your reception is poor.
Actually, yes, sir. The P seems like. So can you hear me?
Well, you are breaking up.
Yes,
So,
Abida, continue, please.
So
is
can
there
you
any?
hear me?
Yeah, I think we should have somebody else because your reception is really poor.
Hello. হ্যাঁ,
Yeah.
আসসালামু আলাইকুম স্যার।
Asif?
স্যার আমি Rafique sir.
Yes.
Good night, sir. So I have a different opinion, sir, about the P in the V1, sir.
Yes,
It's mostly, sir, positive there.
yes,
It's supposed to be biphasic, but it is a fully positive in V1. We can see
yes.
here.
So what do you think is the diagnosis?
So, sir, most probably it is a, sir, atrial tachycardia, sir.
With one-to-one conduction?
Sir, there seems to be a P in the just after the QRS.
Yes,
So,
in V1.
Ji, sir. Yes,
So
sir.
this looks, so I mean, one of the things, I would start with a diagnosis of sinus tachycardia, but then as you said, P wave in V1 looks totally positive. So most probably an atrial tachycardia, and in lead 2-3 AVF, I cannot see a definite positive. And then there is a possibility of second P wave. So what is your diagnosis now?
So my diagnosis is a atrial tachycardia with a 2:1
One.
block, sir.
Yeah,
2:1 blocks.
yeah. So if it is 2-to-1, then the atrial rate is 250. That's a little too fast for atrial tachycardia. So you can either call it atypical atrial flutter with 2-to-1 conduction. And so am I correct? What do you think? So we always need proof of this. And anything else you will describe in this ECG? QRS looks normal. ST segment, non-specific T wave flattening. Those are the things that you have to say. So what we did cardioversion on this patient. Explain this to me, please. If you could explain it to me. What's happening here?
Okay, sir. So after the cardioversion, sir, it becomes.
Can you explain the cardioversion tracing? What are these pointers?
So these are QRS, sir.
And then why?
Synchronized.
Yes, so these markers, this black triangle, they are telling me that this was synchronized to the QRS complex.
Yes, sir.
And as you can see, I gave a 200 joule shock and it converts to a defined rhythm, much
Yes.
slower.
Yes, sir.
And this is sinus rhythm with first degree AP block.
Yes,
Okay,
sir.
thank you.
Sir,
Yes.
can I interrupt, sir? Just
Yes.
for a second, just for the discussion. If someone says in that first ECG that
Yes.
the V1, the P, the apparent P is the RBBB, incomplete RBBB. The second peak and the QRS is the RBBB, incomplete RBBB.
Yes, yes. So yes, absolutely right. So looks like RSR pattern. But
Yes,
look
sir.
at lead V2 also.
Yes, sir. Yes, sir. As the rate, as you all know, sir, the rate at 80 or atrial flutter, we usually find the rate around 150. As the rate is little bit lower, so if someone mistakes it as incomplete RBBB, is it
Yes.
acceptable as in exam?
Okay. So let me, Tushar, really, that's a good question. So I can diagnose this either sinus or atrial tachycardia rate of 125 with right bundle branch block. But look at lead V6. There is no terminal S wave. You expect if somebody has this kind of right bundle branch block, there should be a S wave in lead V6 and lead 1. And also, if you look at the component, it's a little too sharp for, so, but this is definitely in a differential diagnosis. Absolutely right. Thank you, Tushar.
Thank you.
Okay. So this cardioversion, and this proves that this was an atrial tachycardia because, of course, this patient, look at the bundle branch block actually persisted. There is a degree of bundle branch block in this patient.
Yes, sir.
Yes. So can somebody explain this one to me? Anybody?
Anybody interested? Just please
Anyone
raise your
from
hand.
Nepal? Our Nepal's friend.
Oh, good.
I think you can ask Bisal.
Yes. Arun Maski, welcome.
Yeah, Bisal. Bisal,
Yes.
you want to say?
Vishal Shrestha, right?
Yes, sir.
Okay.
Am I audible, sir?
Yeah, sure.
Yes,
Yes.
yes.
Sir, I could not get the question, sir. Like,
The question is, I put up this tracing. Can you explain the tracing?
sir.
It's a simple tracing of cardioversion. Just
Okay,
explain it to me.
okay, sir. So first two QRS complexes, they are synchronized, and the 200 joule synchronized biphasic DC shock was given on the, and then after third, fourth beat, we can see there is P wave followed by long PR and then followed by QRS. The rate
Good.
has decreased, and previous ECGs were quite like they have rate of around 60, and the later part ECG they have a rate of around 40-50, but the wave are still
Sure. Okay.
like atrial tachycardia is still
Yeah,
persisting.
this was probably atrial fibrillation. Okay, so please stay with me. And this is another patient. Same thing. You stay with me. And again, so 200 joules synchronized did not convert. We repeated the 200 joules, then it converts. So we normally can give up to 3 shocks. First shock and then the second shock. Now, please tell me what happened here.
Here, sir. So in first part, the top left part, there is a white complex regular tachycardia with some ECG variation, and there is the QRS were synchronized, and then 75 joules was given after certain period, after maybe around 15-16 beats, and then it converted to even polyphagic white QRS complexes, sir, with tachycardia.
Yes. So it went into VF,
So it
right?
did not convert. Yes,
No,
sir.
but it not only it did not convert, it went into a dangerous rhythm. So what do you think? Why do you think it happened?
Probably this the synchronization was not up to the mark, and there is R to R on T phenomenon, sir, probably.
Yes, look at this. So what happened? I pulled up a couple of tracings from my medical record. So this is where it was not synchronizing on the QRS complex. It was actually synchronizing on the T wave. And this is more likely to happen. So when you do electrical cardioversion, you can either connect it to ECG, lead 2-3 AVF, or you can connect from the pedals. This is more likely to happen if you do it from the pedals. So keep an eye on this. So what will you do at this point? When the patient goes into VF, what are you going to do?
So I'll give synchronized cardioversion, and then magnesium sulfate, if there is available, then magnesium sulfate we can give, sir.
No. Please wait. So you are doing the cardioversion. You do the shock, your patient goes into VF. At this point, what will you do? You will give synchronized cardioversion again?
First, I would like to correct the synchronized part of this synchronized part of the this what is that calibration, sir? Because it is not synchronizing properly. It is synchronized in Q.
Okay, but when somebody goes into VF, you want to give a synchronized shock, because look at this. These waves are big, these waves are small. There is nothing to synchronize with. So if somebody goes into VF, keep yourself quiet, calm, change the output to maximum, go to asynchronous and give another shock. Remember, as soon as you give the shock, device goes into asynchronous. That's a safety mode. Just charge the device, give a second shock, patient will be fine. But at this point, if you change it to synchronize it again, you will delay time.
Sir,
Right.
Again, I have a question, sir.
Yes.
If anybody gives synchronized DC cardioversion in this VF patient,
yes,
as there are some of the complexes have long amplitude, will it give the shock?
It may. It may. You see, the reason you don't want to synchronize in VF is because some of the complexes are so small that the device will not see anything to synchronize. But as I told you, if you are lucky and if you shock at this point, it may give you the shock. So, but at the time of VF, you have to keep yourself calm. So I think this is true for any complication. When things go wrong, to train yourself to keep yourself calm and give a asynchronous shock in this point. This is another patient that happened, same thing, that was in VT, white coerced tachycardia. It really became polymorphic after the second shock and didn't convert. So now let's change the focus. I want somebody to read me this ECG.
Sir, can I read, sir?
Yes, please.
This is the 12 lead ECG, and this is the ECG showed the rhythm is paced. I can see the spike before the P in each lead, and the QRS complex is narrow, and the Q after P, the PR distance, the duration is almost same in all leads. So I think it's a atrial paced ventricular sensed pacemaker, probably I think dual chamber pacemaker. I think so.
Okay, so you made a comment that probably dual chamber.
Yes, sir.
Because there is an atrial pacing spike, it is definitely atrial pacemaker.
Yes.
How do you know it's a dual chamber?
So because the PR is constantly same, sir, in all leads, so I think it's a dual chamber, and probably the pacing is towards septum, sir, or east bundle, because the complex are narrow.
Okay, so what happens if it is just AI pacemaker? Don't you think you will get the same ECG?
Yes, sir.
Yes. So even if the patient has dual chamber pacemaker, from this ECG, I cannot tell whether it's a single chamber or dual chamber. So my comment will be atrial paced rhythm, first degree we block borderline prolonged PR interval, QRS duration, ST segment T waves are normal, right?
Yes.
That's it. I will not make any more. So as you did this one, I would like you to do this one also. It's a different patient. Rate is 60.
Rate is 60, sir. Sorry.
So look at the V1.
Yes, sir.
P wave, what is this?
Atrial pace, sir. Atrium is paced.
Good. Good. Atrial paced rhythm. So describe the ECG. Can you do the whole thing for me?
Atrium is paced, sir, and ventricle is sensed, sir. Yeah.
Okay.
And
we cannot say ventricle is sensed or not. Ventricle is conducted.
Ventricle is conducted. Yes.
Yes. And anything else you want to add? You see, the reason I put these two ECG together, I'll go back, except for atrial pace, this ECG is totally normal. But this ECG is not. So when you read that, you also have to read the other part of the ECG. What else is there? V1, V2, V3, V4. Almost a Q wave, right? Or poor R wave progression.
Yes, sir.
You have to describe that. And then T inversion in lead V3, V4, V5, V6.
Yes.
So what is the diagnosis, final diagnosis? Atrial pace rhythm and
anterolateral ischemia.
No, it is possible anterior MI because there is almost a Q wave, right?
Yes.
And T inversion, I'm going to describe the T inversion and consider ischemia. I will not say definite ischemia. And also there is inferior T inversion. You have to describe that. So the reason, so the point of putting this to ECG is that when we look at a pacemaker ECG, it is not only pacemaker ECG, it is also an ECG. If it is conducted QRS complex, then you can read the other part, and you have to read the other part. Thank you, Manoj. Thank you very much.
Thank you, sir.
I'll skip this one. And somebody do this ECG, please.
So, shall I try, sir?
Please. Who is this?
Sir, this is Chitraraj Sharma from Nepal.
Okay, please.
Sir, this is 12-lead ECG calibrated in normal 25 millimeter per second and 10 millimeter per millivolt. And this ECG showed in lead 2, in rhythm lead 2, P wave, it is biphasic P wave is there, and PR is normal, and QRS it is narrow complex QRS, and
Yes.
ST is normal.
Okay.
And ST is normal, and QT looks normal, sir. QT duration is normal.
So what is your diagnosis?
So with this biphasic and prolonged P component, looks like one differential diagnosis would be the mitral stenosis, sir.
Yeah, that will be a clinical from ECG diagnosis. What will you have done? So is it sinus rhythm or ectopic atrial rhythm?
Looks ectopic atrial rhythm, sir.
Okay, fine. So look at it, but look at carefully in lead V1.
Yes, sir. V1, yes, sir. Sir, P wave is inverted, sir.
Yeah, but what is there before the P wave?
Sir, there is
So look at this. I have magnified it. You see?
yes, yes, sir. It is biphasic.
No, but what is this sharp thing?
Sir, it is not pacing rhythm, but
Yes, it is pacing.
Yes, yes, sir. It's pace. Atrial pacing.
Yeah, atrial. So you see, what's happened? The reason is I always give ECG in a sequence. Some of the ECGs that I showed before had big spikes.
Yes, sir.
And sometimes low output programming plus filtering of the machine, the spike can be very small. And actually, this is an atrial paced rhythm. And that's why the PO morphology is kind of funny.
Okay, sir.
So keep an eye on that. And a lot of the modern pacemakers are programmed low output, lot of filtering system. You can barely see the spike. And so you keep an eye for that. That's how you know. So this is again an atrial paced rhythm. Thank you.
Okay, sir.
Sir,
Yeah.
sir, again, sir, sir, can I ask a question, sir?
Sure.
Sir, if an examinee,
Yeah.
in the exam, when we have given the ECG,
Yeah.
if someone fails to recognize the spike
Yes.
and say ectopic atrial rhythm,
Yes.
will he get pass or
Okay.
he should be penalized?
No, this ECG we will never put in exam in America. We will not give this. And if we do give it, we will give it as a test question to find out how many people can answer it correctly. Because forget about the examining, a lot of practicing cardiologists will miss this spike. So it will be unfair to put this question in an exam. It's good for education, but if that answers your question.
Thank you, sir.
Yeah. Anyone wants to do this one? I will help out if somebody wants to.
Can I try, sir?
Yes. Who is this?
So Bisal, sir. Bisal from Nepal.
Okay. So Vijay, I will tell you some part. You look at the QRS complex, also look at the rhythm strip. Tell me.
Yes, sir. So this is 12-lead ECG with rhythm strip showing showing atrial paced rhythm in third repeat, whereas first and second beat are both sense, atrial sense and ventricular sense rhythm. Third beat is atrial paced, ventricular sense. Fourth, fifth, sixth, all are the same, but seventh, both sense. 7, 8, 9, 10, 11, 12 are both. They are just sensing, and we can also see Q waves in V1, V2, V3, and with T wave inversion, and probably with RBB morphology. So QRBB morphology, probably with old MA and then atrial pace.
Okay.
And some bits are atrial sense.
Yes. So, and how about this beat? It's an atrial premature beat, right?
Yes, sir.
Yeah.
Two bits
so
are
describe
atrial
that
premature.
also. So
Second beat
absolutely right. We have sinus beat, a premature beat, atrial paced, atrial paced, atrial paced, atrial paced, and then sinus beat and a premature beat. And then you also looked at right bundle morphology and with an old anterior myocardial infarction. So I'm going to look at the timing. Look at the timing. There is a P wave here. The pacemaker probably set at age of 60, 1000 millisecond, it paces the atrium. 1000 millisecond paces that 1000 millisecond. This is actually 980 millisecond. If you look at it, this is actually a pseudo fusion beat because it's probably the conducted P wave. Because the P and QRS at the P native P wave and the spacing spike almost at the same time. And then of course 880 millisecond, it doesn't need pacing anymore. Thank you. Can somebody do this for me?
Sir, can I try, sir?
Please.
It's me, Dr. Manoj Koirala from Nepal, sir.
Yes.
This is the 12-lead ECG with rate of 60. I can see here the spike, the pacing spike in front of QRS complex, and the morphology of the QRS complex is LVV type. So it is a paced rhythm with a single ventricular RV pacing.
Yes. And what is the underlying rhythm?
The underlying rhythm is ventricular paced rhythm, sir.
Yes, but what is this complex?
This
is underlying sinus beat.
Yes, underlying sinus beat, sir. Yeah.
So you actually did good because you have to describe it's a ventricular paced beats, but underlying sinus rhythm. Why it's important? Because if somebody has underlying AFib, you have to describe it and they may need anticoagulation. So this is probably a patient with complete heart block who got a single chamber pacemaker. Fine. I think I'm going to do, it's getting late. I'm going to do one more ECG and then we'll stop. Okay. Well, who will do this ECG?
Sir, shall I try, sir?
Please.
Yes, Sharma.
Yes, sir. This
Keep
is
it simple. There is nothing but heart rate 71.
Yes, sir. 12-lead ECG, calibrated and at normal range. And in this, the P wave, it's coming to lead one. P wave is normal, and after P wave, there is the pace rhythm before starting of the QRS rhythm.
Yes.
And QRS is wide complex and LV morphology are type, and QT it's looks normal, and ST and QT duration is normal, sir. And
so what is your, so one of the thing is that when it is a paced rhythm, it is difficult to make too much comment on the ST segment QT interval.
Yes.
So what is your final diagnosis?
It's ventricular RV paced rhythm, sir.
Yes, but is it a single chamber or dual chamber pacemaker? So there is a P wave followed by pacing spike and QRS. P wave followed by pacing. So it is sensing the atrium, pacing the ventricle.
Yes, sir.
Right?
Yes, sir. Yes, sir.
So it's a dual chamber pacemaker.
Yes, sir.
Right?
Yes, sir.
Okay, now remember the date, 28 February 2000. 7 years later, same patient. Now the heart rate is 65. Explain this to me, please. Look at lead V1.
Yes, sir. There is PR is prolonged, sir.
So there is a big difference, right? There is no relation between P and QRS now.
Yes, sir. Yes, sir. There is variable PR duration, sir.
Okay, so there is AV dissociation with the ventricular pacing.
Yes, sir.
What happened? What happened?
Then atrial.
This is the patient has dual chamber pacemaker in 2000, and in 2007 it goes to a rate of 65, and there is no relation between P and QRS complex. Anybody can answer and explain this to me.
Atrial lead is not working, sir.
Yes, sir. Atrial lead is not working.
Okay. Why then? Why the rate is 65? My pacemaker probably is programmed at 60. That's one option. Yes, the pacemaker atrial lead is not working. What is the second possibility? So you have to remember this. Pacemakers, when the battery gets depleted, there is different mechanism of conserving the battery. Medtronic has a default mode that if Medtronic pacemaker becomes ERI, it goes to a rate of VVI 65. This was a Medtronic pacemaker. St. Jude pacemaker will go to a fixed rate at the program lower rate, dual chamber. So these are the mechanisms that you, this is a Medtronic. The Medtronic pacemaker, if one day it shows up in your office, a dual chamber pacemaker rate of 65, you know that this pacemaker has become ERI. That's the default program, and it is done so that the pacemaker doesn't stop working suddenly to save battery. And in this mode, you won't be able to program too much. It will not be rate response. It will conserve battery as much as possible. All right. Any comment from anybody? Otherwise, we're going to, this will be our last slide. Thank you for participating.
Sir, is there any explanation? Sir, the lead V1 is in RBB morphology. Is there any explanation, sir?
Well, I don't know the lead position. Sometimes what happens is, depending on the apical position, this is not a biventricular, because this is 2000 pacemaker.
Yes.
And so sometimes the leads, if you put it too far apical and the RB goes, right ventricle goes under the left ventricle, you can see a positive complex in lead V6. But look at this V4, V5, V6, that's the apical lead.
Yes, sir.
I think that's the only explanation that you have for this.
So is it, sir, due to the rotation of the heart in some patients?
Yes, I think so. We see it from time to time. I mean, we had also, sometimes we had concerns that maybe the position is wrong. The other part is that funny here is that look at lead AVR and AVL, they should have been positive. But I wonder if they put the lead wrong or not. Probably not, because this is the lead position is fine here. And of course, in the old days, if we saw something like this, we always thought about perforation, that a lead can perforate and go into the left side. That is very, very difficult to do because you have to perforate the septum and go inside the left ventricle.
Sir, I have the last question, sir. The ECG that you have shown, the paced ECG, with atrial complex or the sinus rhythm. If in Holter, someone has to mention the rhythm, what they say, what they have to say, ventricular paced rhythm with or sinus rhythm with ventricular paced beat. Yes, sir.
This one?
No, sir. The ECG before, which had ventricular paced rhythm, but which have isolated atrial activity.
Yes. So what I say, ventricular paced rhythm with underlying sinus beat or underlying P wave. If I have a 12 lead,
yes, sir.
If I have a 12 lead, I can confidently say this is underlying sinus. And as I told you, that there is the importance for that, because if it is sinus, doesn't matter. But if it is AFib and you don't recognize the atrial fibrillation, you will not anticoagulate the patient. That's why the underlying is important.
No, sir. The reason I asked the question, sir, we sometimes have to write the comment on basic rhythm in Holter. So if there is P wave is visible and the paced rhythm is there, what the basic rhythm we should write?
Yeah, this is a paced rhythm, because that's the rhythm that we are focusing on. Okay. And here, for the description of semantics, I'll say ventricular paced rhythm with the underlying sinus beats.
Okay, sir.
But the rhythm itself is ventricular paced rhythm. So in Holter, you will have to say ventricular paced rhythm.
So it is the driving ventricular thing that we should comment on basic rhythm.
Yes, absolutely, in Holter, definitely.
Okay.
All right, thank you.
Thank you, sir. May I request Professor Atahar Ali, sir, to wrap up the session and give the remarks. Atahar Ali, sir.
Thank you, Dr. Tushar, and thanks everybody. And finally, thank Rafique Ahmed sir for describing the excellent, beautiful ECG, sir. Actually, there are good comments in our chat box about your ECG presentation. Actually, I have learned a lot, sir, about that pacemaker ECG today. Beautiful presentation, sir. And actually, I like to thank our dear participants. This program is for you, and we always appreciate your participation, particularly our Dr. Abida, Poppy, and some more participants from the Nepal. We always encourage your participation. We are waiting for you. Thank you very much for your participation, and we'll appreciate your participation every day. Thank you very much from participation from Nepal and Dr. Abida and the Poppy. Thanks everybody. Rafique sir.
Thank you.
Thank you very much, sir, for your excellent presentation, sir. And the program will go in 2 days. That is the 2 Sundays in every month, sir. That is
okay.
Good. The second and fourth Sunday, sir.
Sure. All right.
Thank you very much, sir. Thank you, sir.
Bye. Bye.
Thanks.
Assalamu alaikum, sir.
Oh, hey.
Atahar bhai.
Hey, সামনের দিন কিন্তু তোমার প্রেজেন্টেশন
এই 23 তারিখে
হ্যাঁ মানে যে তুমি খেয়াল করো, আমি তো ভুলে গেছিলাম তোমার কথা, প্লিজ।
Thank you, Atahar bhai.
Oh, Salam bhai, thank you very much for আপনি এতক্ষণ আছেন।
We learned many things about the